Thank you very much, Professor Michael O'Donnell, the Richard D. Williams Professor of Urologic Oncology and Director of Urologic Oncology at the University of Iowa. Thank you very much for joining us this afternoon, sir. It was a pleasure to hear you speak at AUA on gemdosi and some other interesting topics around bladder cancer. I think what one of your colleagues referred to you as, it was almost complimentary. It wasn't the mad professor of mixing things up in oncology, but it was something along those lines. I forget exactly.
No, it was the mad scientist of
Mad Scientist, there we go.
Which I took as a very personal compliment.
It's good. And what we'd like to speak to today is some of these sort of mad science things. I'm an orthopedic surgeon by training, so if you could keep the words short and the concepts relatively simple, then I won't bleed from my ears. But I have a rough understanding of the world. I'll probably say something horrible about urologists on the way through, but you're more than welcome to punch back.
I don't expect any more from a bonehead, so it's okay.
That's exactly right. You have all the same jokes over there that we have. Yeah. You could just give me a little overview of what you're working on at the moment.
Sure. So I've been very interested in developing combination chemotherapy intravesically for bladder cancer. And I've been working at this for about 20 years. And it struck me when I first started out as unusual that in medical oncology, you practically couldn't find any single agent therapies for systemic disease. Yet in urology, we had limited ourselves to simple drugs put in the bladder, such as adriamycin, mitomycin, thiotepa, and so forth. Mm-hmm. And the results were, better than placebo, but quite substandard, especially when compared to, a relatively unusual biological treatment, which was BCG. Yeah. And I wondered, why couldn't people do more than one drug in the bladder? It just happened at the time, the drugs that were all available were so-called vesicant drugs. That is, they were the types of drugs that if they extravasated from a systemic therapy infusion would cause significant tissue necrosis. That's how vesicants basically established their names, is they would cause terrible tissue reactions, tissue necrosis, and so forth. So it struck me as perhaps the reason why there was no successful use of combination therapies in the bladder was that the dose-limiting toxicity was actually chemical cystitis. I was able to dig up, and there was an intrepid Japanese clinician, urologist, who came up with a successful treatment of same-day adriamycin and mitomycin, and used it for carcinoma in situ, and was getting 75 to 80% complete response rates, but fully 3/4 of the patients had debilitating cystitis. Yeah. So that sort of sunk into me as this is a problem. And as new agents became available, such as gemcitabine, docetaxel, and others, we started to move into the possibility of there being non-vesicant drugs. So the first thing that I tried to do was combine, and did successfully, a single day treatment of two drugs, gemcitabine, mitomycin. And this was for patients that had failed BCG, for which conventional single agent therapy was relatively poor, looking at 20% 1-year disease-free rates and so forth. We actually got a very reasonable response, 50+% 1-year disease-free rate. And at 2 years, it was still at 35%. We had the typical effects of mitomycin, the hand palmar rashes, the bladder irritability, stone formation, things like that. So it wasn't any worse than mitomycin, and it looked like it was a better agent. It just so happened then, like many drugs in this current century, it went into shortage. Mitomycin went into shortage. At the time, Jim McKiernan at Columbia was just publishing his work on single agent docetaxel in the bladder, and very low toxicity, and yet a signal that was almost equal to Gem-Mito. So I switched from gem-mito to gem-dosi. And first of all, we noticed there was almost no drug toxicity, both agents being non-vesicant drugs. And secondly, we got very high levels of response. We were getting 60 to 70% complete response rates, even in the very refractory BCG unresponsive CIS patients. And our durability was much greater too. We were still seeing levels of durability in 35% at 3 years later. Long story short, we then started to expand our indications to papillary disease, to early failures after BCG, maybe after one cycle, to upper tract disease, and even eventually having used this on a few patients that couldn't get BCG as first-line therapy. And our results were nothing short of remarkable. Patients had minimal toxicity, and yet they had extraordinary responses. In the case of, as I was sharing this data with different investigators at meetings, I had a lot of enthusiasm for them to take my protocol and try it at their institutions. We were able to put in a 11 group retrospective database, which was published in, I think it was in May of 2020 in Journal of Urology, where we found that among all the BCG failures, over 50% were cancer-free at 2 years. And among the technically BCG unresponsive CIS population, it was exactly 50%. For the papillary patients, it was 58%. Then the BCG shortage hit in 2019, and I knew that we would not have enough BCG supply to treat all the patients that were both at my institution that were being referred in because we were the academic institution. So I unilaterally, at that point, had treated 35 patients with gem-dosi up front instead of with BCG.
Yeah.
And remarkably, the 2-year disease-free rate was close to 90%. So I switched to everyone, that every new patient that came in basically got upfront gem-dosi instead of BCG. And we just reported at the AUA our results with 107 patients, all with high-grade non-muscle invasive disease. About 40% had CIS, another 40% had T1 disease. So these were the real heavy hitter type diseases.
Yeah.
And our results at 2 years were 84% freedom from high-grade disease and 82% for any recurrence. So we only had like one patient that had a TA low-grade recurrence. So we call that recurrence-free survival versus high-grade recurrence-free survival.
I don't understand. I don't have 20 years, but I'm getting close to 10 now of traveling around the world, seeing these in everywhere else. The US is drug choice has always been slightly different, but has been equally singular historically, that you've just used one drug. And everywhere else I go in the world, everybody uses mito. And I could never quite work out why. That my questions to surgeons, why do you use mitomycin? Is, well, we've always used mitomycin. And you'll find some places where they use epirubicin, but the only reason they use epirubicin is because they can't get mitomycin. And we work also in the world of high PEC, which is exactly the same concept of heated chemotherapy additional absorption. But the medical oncologists for abdominal and late gynae surgery, it's like they're Michelin-starred chefs. Everybody has their own mix. They have their own, and there's a wonderful range, a pharmacopoeia of things that are used. And we come downstairs, if you like, to the urologists, and everybody in the world uses what they've always used because it's what they've always used. Why do you think that is?
I think people are creatures of comfort. They like to have a program that works for them, that they've got a workflow that works in their office. Everyone is familiar with it. Even though mitomycin is probably the worst drug you'd want to have your nurses fooling around with, you get that stuff in your skin and you're going to get a blistering scab.
And it's mixed at the bedside in half of the places I go globally. In some places they have to have a fume cabinet and a writ from the Pope in order to mix it. But in half the places, they mix it at the bedside. It's always amazed me.
Right. And this is what amazed me when I started to talk about these two new drugs, gemcitabine and docetaxel, which you could practically bathe in and they would not cause any trouble. And some of the biggest apprehension came from the nursing side. Is that how can we deal with this kind of chemotherapy? You know, whereas I didn't want to tell them, well, you're working with something equivalent of a nuclear bomb, and here's something that's a firecracker by comparison.
Do you hope that, well, I said I'd be rude about urologists. I'll mind my P's and Q's, but I'll come in from a slightly oblique angle. What little bit of urology I did 100 years ago at the Whittington Hospital in London with Dr. Miller, if memory serves, it's been a long time. And you know, we used BCG and we used mitomycin, and that was it. And then 20 years later, that's the same. But if you wander around AUA, as we did a couple of weeks ago, there's 1,000 new innovations. If you come forward one organ to the prostate, you know, back in my youth, you were given a monopolar loop and told to get on with it. But there's every form of energy and knot and tie and stent and some barbaric nitinol cutty thing and all voodoo, anything you can put your, and yet we go back an organ to the bladder and everybody still does the same as they've always done.
Exactly.
The urologists seem quite innovative in some ways, but they seem enormously conservative in others.
They're innovative when it comes to toys, when it comes to, you know, lasers, ultrasonics,
robots,
microwave, whatever you want to call it. And they love the idea of playing with a new instrument. However, when it comes to chemotherapy, they are reserved because no one has been trained as an medical oncologist. And so as long as it stayed in the bladder and didn't get anywhere else, urologists were comfortable with it. But that's why pembrolizumab has been reluctantly used among urologists in the United States, is because they're afraid of it. They don't understand immune adverse events. They've heard of people dying from the disease, and that is enough to keep them away from it.
And it seems a shame because from what was seen, and again, with the greatest of respect, as a very solid but workaday specialty in the 90s when I qualified, the urologists have become the rock stars. As you say, all of the toys, up to and including the, you know, the robot, which you can put your chin on your elbow and talk to anybody about in the saloon bar, and they've all heard of the robot.
Right.
But I don't think many people realise that it has become a tool for prostatectomies and radical cystectomies. I can remember seeing some valve replacements being done with it about 15 years ago, and we thought it would be the cardiologists and the neurosurgeons, but you guys have stolen the march there. Is it the difference between devices and drugs that you're quite happy to be innovative with one because then it's still in your own hands, but if it's a drug, it moves into other people's areas?
That's exactly the reason, I think. Like you hit a nail on the head, so to speak.
That's a strange one, because even, you know, BCG always seemed a fairly, what should we say, an orthopedic response to the problem. Let's give a part of the body this terrible disease that the body will then attack, and it might coincidentally cure a secondary disease that you already have. It's always seemed a fairly blunt instrument.
It was, and it still is.
Yeah.
And we, even 40 years later, we don't precisely know how it works. Because everything you look at that involves the immune system is activated by BCG. And maybe that's precisely why it works, is because it turns everything on. And it's like throwing a hornet's nest into the bladder. And
that's how, you know, I can't discuss immunology too much without bleeding from my ears, but that's how I see it in my sort of simple linear brain, that you've just caused such a massive immune response. And it's strange a little bit that more drugs haven't been mixed, because the abdominal surgeons use all sorts of stuff, and they have to put up with a much greater systemic toxicity because they're lavaging your abdomen for 90 minutes with it. Nature has been very kind to the urologist and provided a small waterproof bag, largely with only one way in and out. I would have thought this was a prime opportunity to mix up some different potions.
You know, it really is, because you can practically put anything in the bladder, including bleach, diluted bleach. And and call it a different name, chlorpactin, and suddenly you have a treatment for another weird disease, which is interstitial cystitis.
Yeah.
So, you know, the bladder is such a good impermeable organ that the tumors come back so frequently that you actually have multiple chances.
You have plenty of goes to have a go at it, yeah. How do you see this playing out? I won't take you too far into the future because I've got some further questions about that. But BCG failure is still a big problem. It is a disease state that the FDA have highlighted as one of the things that they will fast track almost any effective procedure for. And by effective, I mean, 30% recurrence free at 6 months, which doesn't sound massively effective to somebody who's used to doing arthroplasties. Where are we going next? What's going to be the next thing?
For better or for worse, no therapy is perfect, and there will always be failures. What that practically means is that there's room on the table for all kinds of different ideas. It's just a matter of when do you pull the plug? So it used to be that, we took bladders out when they failed the second course of BCG, and it wasn't because that patient was imminently about to develop metastatic disease, because we had nothing better to really offer them. At that point, the chemotherapies were at best 20% effective.
Yeah.
Yet, interestingly, the FDA recently approved pembrolizumab for a 1-year disease-free rate of under 20%.
Yeah.
So, we haven't really moved far with the approved medications. Likewise, valrubicin, 8% at 2 years. So now we're seeing these people, several people coming through with proposals where the 1-year disease rate is 20 to 25, maybe up to 30%. There's been some new exciting work from the combination immunotherapists of using the IL-15 superagonist and 803 with BCG and getting results that are actually very similar to what we got with gemdosi. 70% CRs, 60% at 1 year, 50% at 2 years. And likewise, the hyperthermic mitomycin therapies are in the same ballpark. And even in the third world countries, what can be affordable?
I can only imagine, well, I don't need to imagine the answers we'll get for a full course of pembrolizumab, but
$10,000 to treatment.
So we'll speed it up in terms of adoption. I will give you $1 billion or whatever currency unit you like of research money now. What are you going to spend it on? I'll allow you one sort of line of investigation and one big trial.
I would have a prospective randomized trial with several alternatives. I would say 3. Let's take the top 3. Let's take NO3. Let's take the hyperthermic mitomycin, and let's take gemdosi. Let's do it correctly. I think what we'll find is that they're all actually pretty much the same. There'll be a different toxicity profile.
Yeah.
And then I would add to that the ability to do crossover. Because ideally what we want is we want to save as many people using a correct sequence of complementary treatments to achieve something over 90% for the whole population. That's what I would put it in.
Well, we're talking about trying to find one technology that can go forward to treat, in this specific case, BCG unresponsive or refractory bladder disease. But in everything else that you do, as we spoke about with prostates, you've got 10 different things to try. So why not have all of them to try? And from talking to some of your colleagues, this is exactly what they're saying, that we need in our armamentarium 2 or 3 things to either try them as golden bullets or more likely try them as sequential treatments, because somebody's tumors or somebody's urothelium or somebody's something just will not respond to gemcitabine. And
so the
as
second
we can identify these.
That $1 billion would be invested in complex genomics that would hopefully try to identify fingerprint patterns that would increase the likelihood that a particular subset, one treatment will be better in that group than another.
But the urinary biomarkers for tumor in its broadest sense, which would be a great step forward for bladder cancer treatments, but then proper genetically subsequenced, analyzed, I don't even know what the correct word is,
Analog.
biomarkers that show you, oh yes, you've got the sort of TAGT, G2, whatever tumor that we know is particularly susceptible to madafaragine or gemdosi or something else.
Yeah, exactly.
How far are we away from that then? You guys have done nothing but mitomycin and BCG for the last 40 years. How long is it going to be till we get here?
Well, fortunately, I guess, in times of crisis, compromises and changes are forced upon us. And so I wouldn't have gotten this far with gemdosi had it, and certainly not in the upfront setting, had there not been a BCG shortage. And now we have rivals BCG as upfront therapy, which threatens to actually change the whole game. And now we'll be looking at, well, how good is BCG as a second line therapy, or maybe hyperthermic mitomycin would be the next best thing to use. Where does BCG fit into this? Is there a particular pattern of relapse that suggests a completely different mechanistic approach, going to immunotherapy would be better than going to chemotherapy? I mean, there are limited numbers of resistance pathways that probably can be mapped out.
But if we could map them, it gives us a much stronger route through, doesn't it? When our friends at Sanofi stopped manufacturing BCG, and probably not for the tape, but the reasons we hear is that they had a flood, didn't they? And then it was too much work and too much money to turn it all back on properly again.
And they weren't making much money. I mean, that's compared to a drug that is as effective as BCG, it's substantially underpriced.
But we know the guys from Medac very well, the German pharmaceutical company who make both mitomycin and an excellent version of mitomycin, if such and BCG, and they say the same, that we thought 20 years ago that tuberculosis was a disease of the Victorian era and we could write it off along with smallpox and scrofula and whatever else. But nature finds a way. And in the UK, it's about £100 for a vaccine to TB, and it's about £100 for 40 millilitres to put in your bladder. And they can make, and it's something ridiculous, from a full SWOG protocol of BCG for a patient, they can make something like 10,000 vaccines. So I'm no accountant, but I can see where that one's going.
Yeah, and it's you have to, it's like learning from history. You have to know what's come before and how it set the market and set the stage for everybody else. And then you have to decide, well, are you going to throw away the old workhorses, or are you going to remodel them? And
it does look, we see globally now there's a couple of new players and a couple of strains of BCG that are being licensed in extremis. But we're just trying to repatch the same hole in the boat every time it comes. The time has come now to move to a different, not single therapy, but raft of therapies. It's too much of a nautical continuation of cliche. A raft of therapies that will give you guys as many options for bladder tumours as you've got for BPH, as you've got for incontinence, although you've lost most of those now, as you've got for other treatments and other treatments.
I totally agree.
Okay, so we'll look at it slightly differently then. I have in my garage here in Yorkshire the DeLorean from Back to the Future, so I'll throw you the keys.
I'll tell you what, I'll race you with the Tesla.
I'll throw you the keys to this, and you come back into your uro-oncology clinic in 40 years' time. What does it look like?
Well, the goal of every surgeon should be to make surgery obsolete. So I think we're gonna have some form of nanotechnology.
You're not the first to say this.
Smart nanotechnology. You put in the bladder, it has particular sensors for certain protein signatures that target a small little ionic blast and wipes out the cell, and it's so specific because it requires 3 different triggers that all must be present at the same time. And you may throw in a little bit of something else for sort of overall coverage, but your money's going to go with this extremely precision smart bomb approach.
Yeah, I know you're not the first to say. I don't know. Well, I don't know of any companies who are working on this now, but I bet they're out there.
My daughter's an engineer, and she was telling me that they've got these little things that can crawl around and they can send little homing signals already. So it's already in there in infancy. It's just a matter of applied, engineering.
How do we get there? Are we getting there through gemdosi? Are we getting there through some other immunotherapy, or are we getting there through a whole raft of new options?
Well, I think what has to happen is you have to have something that first works and that it can apply a benefit. And then you've got to incrementally go beyond that and start to invent new therapies to take up the gap. And then as those therapies become more effective, they'll basically wipe out the old therapies.
Yeah. And we're hoping to start to see a little bit of that now. I mean, we say there's no innovation, but we've seen the pembrolizumabs and the PD-1, PD-L1s, the nadofaragines, some of the immunologic stuff that I can't understand because my brain's too small, and some of the more straightforward, well, I guess very not straightforward, but more replicable things from other surgeries or other specialties, whereby don't just use the same drug all the time and expect to get different results.
Nor can we take two ineffective drugs and expect that they're going to be effective. Somehow they're mixed and matched one week versus the next. And that's what a lot of what happened with the Europeans, attempts to combine immunotherapy with chemotherapy. We're basically just alternating week by week, or 3 weeks in a row with one, 3 weeks in a row with another. And that's relatively naive, I would say.
We have a 2-year study from Leicester University in the UK, which is, Leicester's not famous for anything particularly. They won the Premier League a few years ago, much to everybody's amazement, most probably themselves more than anyone. But they have a large university there and a very large urology department. We found good results on a sequential therapy, but it was based upon, I've only got 3 doses of BCG per patient, so that's all I'm going to use, and I'll fill the gaps with something else. And whilst the headline results were good, we don't know why. We don't know if the immunotherapy boosts the chemotherapy or vice versa, or it just gives us twice the drug to go for 2 different sorts of patients, one of whom would be appropriate for chemo, one would be appropriate for immunotherapy.
Right. So it's like throwing a bigger bomb at them. Oh, 2 bombs.
Yeah.
Incendiary and something
even worse. Fine. Okay, lovely. Is there anything else that you'd like to add or like to talk about? I mean, that's generally run through my box of tricks. Is there anything else that you think's interesting, innovative, that we haven't covered that you'd like 5 minutes on?
I think that would cover most of it. I think that there's a lot of talk about, coming up with an MRI-based better method of evaluating bladder tumors and so forth, but it's sort of like the PIRADS for bladder. I forget what they call it, this CIRADS, I don't remember what they called it, but I'm not really too impressed by that. I think even such things as photodynamic therapy will make a return as we begin to understand the physics of effective energy transfer, and we can now have more efficient targeting. The whole fact that immunobiologicals are being created that allow specific targeting, I think is going to be a big deal. But I think we've only scratched the surface on that one. So I think that I wouldn't be surprised if we see something like quantum dots that are highly efficient at transferring energy, being coupled with very specific antibody or aptamer-related targeting proteins or nucleic acids to get a more focused concentration of energy effects. So I think we'll probably move through that at one point too.
Because the ablation of the tumors or the surgical removal of the tumors is it's as undeveloped as the treatment thereafter.
It is medieval.
It's what little bit I did in probably quite a medieval fashion 30 years ago. It's still the same, isn't it?
Surgery, for God's sake.
I did a little bit of urology just to get, But yes, the fact that you are still, I joked about the prostates being with the monopolar loop, but that's still pretty much what the bladder tumor is, and we know from our work in abdominal peritoneal spread and the pseudomyxomas and these sort of things that the biggest prognostic indicator is the surgery and how close you can get to T0. Now, in the abdomen, there's a lot of space, and you've always lost something or hidden something or not seen something because it couldn't be seen. But I wonder in the bladder as well, if we could not only do what we assume to be a very good TURB, either by eye or by narrowband or by blue light, but we could also do it with an energy that is much more ablative and hopefully focused as well, then that would probably have another big move from it. It's funny, it's such a common disease and so little has been done in 30 years.
I know, it's terrible.
It means that there's a great opportunity for innovation in front of us.
Well, what happened though? I mean, I think what happened is that bladder cancer came into the spotlight. And we have to thank the FDA for that, because they basically created a low-hanging fruit. 100 patients, and you can get your drug approved and make millions of dollars, or billions for that thing. And now suddenly, a lot of players in the game, it has created this energized interest in bladder cancer. And now we're attracting young people, energetic, interesting people who grew up in the gaming environment and understand, a little bit that, the rules are what you make them. And I think that's going to be the new vitality in bladder cancer. It's going to come from that. We're seeing it. We're in the cusp of it right now, almost in the middle of it. And it's exciting, and it's very thrilling to have come through 20 years of agony and finally start to see some of the fruits of all that labor.
Wonderful. Okay, well, that's great. If we can look forward to that in the next 10 years. I didn't think we would finish the interview by thanking the FDA. It normally doesn't go that way, but we'll take that as an innovation as well. Wonderful. Thank you very much for your time. I'm very interested there to see that it's not just everybody doing what they've always done, that there are some innovative, intellects out there looking to do the next big thing for it. So
that's where the fun is.
We're just trying to put some interesting content out there about how we should be treating bladder cancer, and hopefully it just helps keep it something that people talk about and maybe moves it along one iota.
I love it. I totally love it. Thanks for involving me.